now let's go ahead with the second. Sir, who is the second person? Dr.
Tapas Sahu.
All right. So let us now welcome Dr. Tapas Sahu. Sir is a very well-known figure. He, in fact, is the founder of the General Secretary of the Nephrocritical Care Society. We all are aware of the work extensively being done by the Nephrocritical Care Society. And he's the Associate Director and Head Critical Care Medicine at Medanta Hospital, Ranchi, India. And he's also the Director of 360-degree Critical Care Academy. Dr. Tapas Sahu, I may please ask you to share your screen. And Dr. Tapas Sahu will be speaking on fluids in AKI and CKD patients. Let's not drown them. The topic itself is very interesting. So let's hear it from Dr. Tapas Sahu, and we'll take the questions at the end of the lecture. Thank you.
So good morning, everyone. Is my slide visible?
Yes, but there is nothing written in the slide.
Yeah. So that's the first thing that I have tried to do it, and not losing anything from now. So very good morning, good evening, and I think there are people across the globe who have joined in this very fluidic discussion. And thank you very much, Dr. Tapesh Bansal. And this is, I hope, the third time we are having together the discussion related to something very relevant in current today's practice. Thank you, Dr. Uma, for introducing. And I would be talking about fluids in AKI and CKD patients. So hopefully our patients should not be drowned, and that should be the category and the whole aim of this discussion, that we should be doing justice to our patients who are in our ICU struggling for life, and they are having AKI and CKD. And from the very beginning, my disclaimer, as Dr. Uma has told, I have been associated with Nephrocritical Care Society intricately, and it is a society which is trying to raise the awareness as well as some new novel initiative across the globe related to this important aspect of our critical care practice. Now, we never want our patient to look like this in our ICU. If he or she is not intubated, admitted for some or other like a very standard disease, or else if our patient is admitted with so many other problems with multi-organ failure, we never expect that the first look when we enter into our ICU, the patient should not look at us in this way. So this is the thing that for that reason we are actually having this topic today. So if we'll be again analyzing the topic title, it has two spectrums. First one is the fluid therapy, and the second one is acute kidney injury and chronic kidney injury. You can guess which is the acute kidney injury kidney and which is the chronic kidney injury kidney disease kidney. Now, always I try to start with some clinical cases so that it can set the tone of our topic discussion rather than starting theoretical. So if we can get this type of patient in our ICU, in our emergency department, a 48-year-old male with severe septic shock in the emergency department, the patient presented with blood pressure of 64/33. And when we evaluated the patient, the lab reports came, and you are getting sodium 143, 3.8, potassium 108, chloride, the carbon dioxide of 16, and you can see here the BUN creatinine is 35, 2.3 with the blood sugar 133. This is the one the spectrum that I am trying to first start with. Now the second patient, a 45-year female with abdominal pain, vomiting for 1 week. And again, she presented with hypotension to the ED, admitted immediately to the medical ICU. And this is the lab investigation. Significant one is BUN 78 with creatinine 8.5 with sugar of 101. Now, just you can see also the chloride level is also less, which is 64. Now, another patient, a 76-year-old female nursing home resident, admitted with blood pressure of 84/40 and altered mental status with, you can see the sodium is 167, potassium 6, chloride of 124, PCO2 of 21, BUN of 291, 3.5 is the creat, and the blood glucose is 668. Now, I would ask all the attendees here that do you think the fluid therapy that we are going to start or to continue in our ICU is going to be same? How do we know that which patient is going to respond positively and which patient is not going to respond in a great way or great expectation for which we are actually admitting in ICU? So this is the complexity of the fluid therapy in acute kidney injury and the CKD patients. Now, if again we will be analyzing further the spectrum of renal diseases in our ICU, it can be due to AKI, which is the most common and the most relevant one for the intensivist. Is the hypoperfusion, maybe due to any of the region, maybe bleeding, maybe sepsis, maybe contrast associated, maybe something related to post-operative, maybe related to drug-induced AKI, maybe related to obstructive uropathy. Now, there would be another category of patients in our ICU which we normally address and see in our ICU rounds is AKI on CKD. We also sometimes write acute onset of the chronic kidney disease, and that could be due to the pre-existing kidney problems due to diabetic, hypertension, glomerular disorders, and tubulointerstitial nephritis. Now, there would be another set of patients which would be labeled before by the nephrologist or the concerned specialty as end stage kidney disease, but they will be presented to our intensive care unit or to the emergency department with some or other disturbance in the homeostasis because of sepsis, because of cardiogenic shock, because of some major surgery that has happened in a patient who was previously diagnosed as end stage kidney disease and patient is on dialysis. Now, I would be now again asking another set of questions or the practices that we do in our real life. Why do we give fluids to critically ill patients with AKI? Any patient in our ICU, and we labeled that yes, this patient is having acute kidney injury, but we are planning to start IV fluid. So it could be due to the first important thing is the urine output is low. So I definitely need to give some fluid. Patient looks dry or sunken. So definitely that is one of the clinical assessment that is prompting me to give some fluids. Maybe if the BP is low, heart rate is high, and I did my patient's ABG is right now saying that lactate is high. So definitely somebody would be suggesting that yes, this patient needs fluid. CBP, if the patient is having central line, some age-old practices, though we are not following now. But yes, if CBP is low, the dogma is let's give some fluid. Cardiac output is low. Somebody is coming up with another the monitoring device which is showing that yes, this patient's cardiac output is low. So definitely this patient needs fluid to improve the organ perfusion by improving the cardiac output. Now, another set would be patient is bleeding. Definitely along with blood and blood products, I have to give some fluid. Now some resident is doing POCUS at the bedside, and this is something which we do at our bedside day in and day out. So as per my POCUS exam, this patient needs fluid. That can be also another aspect. If I am having some gadget which is having advanced hemodynamic monitoring and I am getting the pulse pressure variation and stroke volume variation which are actually abnormal, that also is one of the reason why I will be giving fluid. And finally, all the guidelines are actually guiding me that I should be giving fluid. So this is the reason for which at least you can correlate in your own clinical practice. Now, if you are giving fluid, definitely you are expecting or you are with the evidence that one of the things have to be satisfying. One is fluids are efficacious, at least they would be achieving the physiologic target. Point number one, fluids are effective. They improve the clinical outcome because we are all trying to improve our patient's clinical outcome. Now, the third one, I will not be doing any harm. At least it has to be safe. So that is the most important criteria for any clinician, that if I am not able to do some good to my patient, at least I am not doing something which would be harming my patient. Now, there would be many questions for the attendees, the clinicians, the trainees like me also. I have to answer some of the questions before I can justify or rationality of the fluid therapy in acute kidney injury and in chronic kidney disease. Like in which patients I have to give fluid therapy, where the conditions where I have to give fluid, what will be the fluid of choice, when, at what stage I have to give fluid, whether it is at the time of admission, whether it is at the second day, whether I have to go for resuscitation first, how to go for the maintenance fluid, why I am giving fluid, that has to be also justified. How I am going to give, like bolus or like infusion, or like the fluid has to be removed through dialysis, through diuretics, and also so many questions would be definitely popping up in our mind. Now, before going into the detailed, I need to explain what is actually happening at the pathophysiologic state. So the pathophysiologic mechanism for any critically ill patient who is having AKI, my discussion would be more focused on acute kidney injury. So these patients are definitely unstable hemodynamically. Point number one. There happens multiple reasons to be having the microcirculatory dysfunction because of sepsis, because of surgery, because of drugs. There would be definitely microcirculatory dysfunction along with macrocirculatory dysfunction. There would be instances where we would be getting the endothelial dysfunction in our patients with AKI. Now, moving further, there would be also microvascular thrombi, inflammation, and all these things would be precipitating tubular cell injury. If my patient is congesting with the fluids, that is also affecting the renal venous congestion, and also there would be instances in our AKI patients where obstruction is one of the primary pathophysiology, and there would be some diseases we all know that would be having autoimmune pathophysiology for our patients deterioration. So these are the pathophysiologic mechanisms. So our patients are not very straightforward, so they are also having some or other problem that is happening at the macro as well as the micro level. Now I am going for a $1,000,000 question, the question with all the dollars in the $100. I can say show you that what should be the way in a patient who is definitely not looking so great. The patient looks edematous or the patient looks dehydrated. The urine output is not great. The blood pressure is not maintaining. I should be going for bombarding this patient with liberal fluid, or I should be very cautious. I should be also having some or other hemodynamic monitoring and go for restricted. Now, for answering the question, we need to understand that fluid therapy is an existential conflict. Since the day one, you do the resuscitation, you are doing good for the patient. You do over resuscitation, you are actually going in the other direction where your patient is getting more and more fluid, and finally it is the fluid overload status. Now, the major goal for which we are actually going to do or the resuscitate our patient with fluid therapy, the noble mechanisms is to improve or maintain the GFR. That is the first physiologic mechanism. Everybody understand, everybody agrees with me. And also I need to improve the renal oxygen level with my fluid. So that is the primary goal. But in the case where my patient is struggling with acute kidney injury or acute on chronic kidney disease, it is not so straightforward. I need to understand that my patient with AKI is having complex and multifactorial etiology. There is also high prevalence of comorbidities in CKD and end-stage kidney disease patients. So the primary physiologic mechanism of fluid therapy doesn't stand valid in a patient who is having AKI, CKD, or acute on CKD. Now, the second one of the rationale of giving fluid is to restore the map. Everybody understands this. The mean arterial pressure has to be good so that the renal perfusion pressure will be also good. And I have to also see for or look for that my cardiac output in my patient has to be good, and ultimately that would be improving the renal blood flow. But it doesn't stand true in a patient who is having all this heart rate, blood pressure, and CBP in a case where the patient is struggling with acute kidney injury and CKD. These are the poorly predictive of the cardiovascular function and adequate renal blood flow. So I need some more information rather than only this heart rate, blood pressure and CPP. Now, this is one picture which would be explaining in little bit of different and deeper way. This is Frank Starling curve. Everybody knows it. We are studying it since like now our MBBS stage. Now, you are drawing this Frank Starling curve in the red line. This is the cardiac output, while the blue color is the venous return. Now, take the example of sepsis or hypovolemia, which is one of the primary cause or the most important cause of acute kidney injury. Now, here the cardiac output is low and your venous return is also not sufficient. Now, you are trying to give fluid so that your cardiac output is in the right now in the steep position or steep portion of the Frank Starling curve. So, you are doing great, and this patient is fluid responsive. That means you are giving fluid and the patient is also showing the symptoms and signs, and the monitoring is also showing that your patient is in the steep portion of the fluid responsive curve. Now, there would be a situation where you are actually crossing this the you can see here, from here it is now going into the more like the overhydration part, which is actually increasing the peak mean systolic filling pressure. Mean systemic filling pressure from here to here, and that is actually stretching the right atrial pressure. And at this time, you are unknowingly crossing the steeper portion of the Frank Starling curve and entering into the flat portion of the Frank Starling curve, and that is going to be detrimental. Now, this patient is fluid overloaded, and there would be definite the complications that we would be anticipating in a patient who is having fluid accumulation syndrome. So this is something inadvertently during our resuscitation part in our ICU, we do not understand. So we have to be very cautious or judicious. That means your target should be fluid administration, increase mean systemic filling pressure, increase preload and increase cardiac output. But you should not over succeed in your all these interventions. Now, moving forward, there are two terminology I want to right now introduce. One is fluid responsiveness. We are all eagerly discussing about this till now. But there is a terminology called as fluid tolerance. Fluid responsiveness is not always that you have to bombard with more fluid, because you are sometimes going in the other direction, which is fluid tolerance, and that is creating problem. Now, this risk benefit, that what to go with the fluid responsiveness or fluid tolerance, that depends on three factors. First one, you need to understand what is the etiology of acute kidney injury, what is the previous volume status of this patient, and what are the types of fluid you are actually using. What should be the timing, what should be the rate, and what should be the volume that you have to give to this patient. Now, in acute kidney injury and in chronic kidney disease patients, there are certain barriers in the fluid therapy. Maybe fluid therapy is suitable for a patient who is not having any such type of problem, or patient coming from the OR, or patient is young without any other comorbidity. But in specifically in acute kidney injury and chronic kidney disease, there is more, like you can say, over the activation of RAS system, renin angiotensin aldosterone system, and there is already increased activity of the ADH system. What will happen to that? Why I am talking about that it is a barrier in the fluid therapy? Because there would be automatically retention of salt and water. So that is again one additional factor that would be aggravating your excess fluid therapy. So you are giving one, there is also another response from the body which is adding 0.5. So it would be 1.5. You are trying to give one, but there is already in the body 0.5. So you have to think about and act accordingly. Now the second point, that all these patients with septic shock and acute kidney injury, we all know this is a state of vasoplegic state. And vasoplegic state, as like the terminology is signifying, there is role of vasopressors rather than only fluids. So you have to understand that what you are actually trying to treat rather than only giving fluids blindly. Now, The third point, microvascular thrombosis, endothelial injury, increased capillary leak, that is also happening in my patient, which is not actually justifying the role of giving more and more fluid to my patient. There is also another factor, which is the shedding of the glycocalyx. That is again affecting the microcirculation part. That will be also should be considered when I am thinking about giving fluids to the patients with acute kidney injury and the patients with chronic kidney disease. Now, this is one picture which can explain what is happening at the capillary level. So we all know this is artery, this is venous system. Now there is the interstitium happening here. If your oncotic pressure is normal, so with the blood pressure at the normal level, you can see there would be the slower loss of fluid from the vasculature. And if you are taking the fluid out, there would be rapid vascular refilling because your oncotic pressure in the vessel is good. But in case this patient is having systemic inflammation due to some or other region of acute kidney injury, you are having low oncotic pressure. So that is automatically increasing the capillary permeability, plasma protein leak is more, and as a result, what is happening? There is rapid loss of fluid from the vasculature, and also if these patients are subjected to some or other form of fluid removal, whether through the drug or through the ultrafiltration by dialysis, there is again slow vascular refilling because your oncotic pressure is actually low. Now, what all these things are actually doing when our patient is with sepsis as well as acute kidney injury because of distributive shock or cardiogenic shock, this is creating a problem with the lymphatic drainage. So the lymphatic drainage is actually exceeding, and that is causing problem with the interstitium edema. And as a result, what is happening? There is decrease in the arterial perfusion because it is ultimately causing problem with just a compartment syndrome. Your intracapsular and subcapsular, the edema is increasing. The kidney is surrounded by more and more fluid, which is prohibiting the venous return. And also that as a result, what is happening? It is creating problem with the oxygen delivery and also endothelial damage and microthrombosis. Now, the second part, what I want to discuss here is the rescue fluids. Here the question that I have shown you all those what, how, when, where is actually more relevant. The questions that is right now in front of me, that yes, the role of fluid is in absolute hypovolemia, in oliguria, in replacing the loss that is happening to the body, or also to change the osmolality. Because if the patient is really hemoconcentrated with high osmolar right now gap in the patient, so definitely I need to choose a fluid which can change the osmolarity of the plasma. And also in certain cases, I am also able to give some nutrition through the fluids. So all these things have to be satisfied when I am actually selecting a rescue. So these are the fluids right now in front of me compared to the human plasma. You can see here the colloids and the crystalloids. I'm not going into detail because it would be repetition of the previous lecture. So you know what are the fluids right now with us in the crystalloid, 0.9% saline, sodium lactate compounded balanced salt solution. In the colloid, whether it is 4% like albumin or hydroxyethyl starch, volume, all these things. Now, there also you need to understand this the exchange across the capillary bed and the Stirling force, what is happening. So if your arterial blood pressure is higher than the osmotic pressure, the net result is that your fluid will be coming out because your oncotic pressure is actually good here. So hydrostatic and oncotic are the two component of the filtration, and that is you need to know about the different constituent of the blood at the venous end as well as the arterial end. Now, the questions right now, I know everybody is confused, and also I am also not very much satisfied at this point of time to answer a question. Crystalloids or colloid, which is better? Within the colloid, crystalloids, are balanced solutions better than isotonic saline? Then how much IV fluid should we be giving? Do we need to give maintenance fluid for all our patients who are in our ICU with acute kidney injury or acute on CKD? How to assess the fluid response and evaluate fluid tolerance? Because I have already mentioned one terminology called as fluid tolerance. So all these things have to be answered before we can come to a conclusion. Now, This is one article which has shown, if you can see here, if you are giving fluid in the middle zone, you are in the euvolemic state. Good. This is good for the patient and for us. Now, if you are not giving fluid and the patient is actually losing more and more, like the third space loss and going into hypovolemia, so you are going ahead with either crystalloids or albumin or isotonic saline. Now, as per the research and the literature, you are doing not bad if you are going ahead with the crystalloids. And in certain patients where you have already given fluids, you are adding albumin. In hepatorenal syndrome, albumin will be scoring better than your crystalloids. So you are in the middle zone. Isotonic saline is going towards little bit towards the harm zone, because we all know it is containing more chloride, and chloride rich fluids would be little bit not very welcome in my patients with acute kidney injury. Definitely Hess and gelatin, I am not going into use this in my ICU for any patients on AKI or AKI on CKD. Now, if I am trying to go and analyze the euvolemic status, and the patient is seems to be like right now at this point of time stable, so I have to also think about, second, that I will be continuing with assessing this patient serially. It is not that once I will be like finding my patient to be euvolemic, I will leave the patient. No, I will be continuing to see the signs of hypoperfusion. If I am getting some or other clinical sign of hypoperfusion, I would be checking assessment for the fluid responsiveness. Now, this patient is showing signs of fluid responsiveness. Maybe I have to go for aliquots of crystalloid fluid. If there is no signs of fluid responsiveness, I will be discontinuing the fluid. Now, on the other side, or the right side, if you can see the hypervolemic state. So in the hypervolemic state, maybe I have to start like loop diuretics. And if I'm getting some good response, it's okay. If not good response, maybe I have to think about diuretic resistance. I have to change the compound. Maybe I have to add a diuretic from other classes. Consider trial of diuretic infusion. Maybe I have to mix with albumin if my albumin is at least more than 2 or 2.5 gram per deciliter. And in case still the patient is not peeing, I have to consider mechanical fluid removal. So this is the diuretic resistance. If I'm getting appropriate response, definitely I have to continue. Now, these are the trials, I'm not going to detail, that have actually shown comparison between colloids and crystalloid. And the verdict is more towards crystalloids. And that has to be again balanced salt solution rather than chloride rich IV fluids in acute kidney injury. Now, this is something we know. ROSD, everybody know. Rescue, optimization, stabilization, de-escalation. Do you feel that this is something which would be again appropriate in our AKI patients? I don't think so. Because all these things, that the early goal directed therapy is for patients who are not having acute kidney injury. In AKI, we have to think about not early goal directed therapy. I can label it as kidney directed fluid therapy, because my first organ which is coming in my mind which would be affected if I am not judiciously giving fluid is kidney. So that's why I can change the terminology to kidney targeted fluid therapy. So what is this? This is a protocolized hemodynamic resuscitation, and the role of goal directed therapy for kidney target is to decrease or eliminate the use of maintenance or replace the maintenance fluids if it is not required. I have to think about decreasing the tonicity of my fluid, use small volume of carrier fluid with IV medicines. So ICU nurses have to be adapted to this kidney care bundles. And also I have to think about giving more fluids in the enteral medications and nutrition as often and as soon as possible rather than IV fluids continuing. Now, this is one study I want to quote. This is the classic trial, and they have compared between like the restricted versus liberal in the septic patients. They found that if you are going for the restricted protocol arm, there is less worsening of AKI. So maybe the SMART trial and the split trial, they have also favored more towards the balanced crystalloids. Though the split trial, they have not got any significant difference between the saline versus balanced fluids. Now, maybe the future is for biomarkers. I need to have some or other biomarkers that can guide me that yes, this patient is having renal stress. and that can help me to guide the fluid management before the traditional marker like serum creatinine start rising. IL-18 cystatin C, that also can help clinicians in determining the necessity as well as the timing of fluid resuscitation in a more precise way. And finally, maybe these biomarkers, if we can add to our existing like parameters, we can reduce the need for dialysis by enabling early intervention. Now, maybe I will be suggesting some or other protocol to all the attendees here, that any patient coming to you in your ICU with some or other like the resuscitation need, you have to go for checking the cardiac output. If your cardiac output is not good, then you have to go for assess for the fluid overload state. Then expect that you are going for some or other negative balance target. If your cardiac output is good, you have to continue thinking about whether my patient is actually in need of fluid, patient is in hypovolemia, then you have to give some or other aliquots of fluid, check continuously whether your patient needs more of fluid, more of vasopressor, more of inotropes. In the other side, if you can think about starting for RRT, go for extracorporeal fluid removal or the diuretics, and think about revising your fluid balance target in a dynamic way. Now, there are many methods of fluid responsiveness. I am not going to detail. In AKI patient, this doesn't stand true. Why? Because all these things have to be added with your clinical examination, cumulative fluid balance, oxygenation index indices, lung ultrasound, echo, and vexus. So it's not the only clinical examination or the static and dynamic parameter, rather all these bunch of the test and examination that hold true, along with intra-abdominal pressure measurement as well. Now, if the fluid responsiveness and fluid tolerance we have already discussed, because we need to also think about how the patient is having the response to our fluid in COPD patients, in CKD patient, in coronary artery disease patient, in abdominal compartment syndrome patient, in severe pulmonary hypertension patient, and in restrictive cardiomyopathy patients. Now, this is the last the algorithm that I want to share with all the attendees here. Whenever you are getting a patient with hypovolemic AKI, what is the problem? You have to evaluate for the increasing or obstructive cause first. Then check for the cardiac output. If it is high, maybe you have to think about some other alternative hemodynamic intervention. If it is low, then go for fluid tolerance. The first one should be fluid tolerance, not the fluid responsiveness. Think about whether your patient is having ascites, which is causing intra-abdominal pressure. In your lung, you are getting more of B lines. In your vexus, which is suggesting that this patient is volume congested. Then you think about whether you are getting fluid responsiveness or not. If yes, then you have to think about whether my patient will be getting benefit with fluid or not. And also you have to think about always, it's a dynamic process, risk, benefit. And my patients that I have shown at the first, this is the answer to all my patients that I have shown in the third or fourth slide, that AKI from true hypovolemia, that is GI fluid loss, the fluid tolerance is yes, fluid responsiveness is yes, maybe I have to think about giving fluid because the benefit seems to be more for me. In a patient who is having AKI, young patient with sepsis, no comorbidity, fluid tolerance is yes, fluid responsiveness yes, maybe this patient will not require fluid for a long time. Sustained fluid benefit is not there, possibly not there. So benefit, the percentage is actually less compared to the first case. Now, third case, AKI in a resuscitated young patient with pancreatitis. Now this patient is having B lines on the lung ultrasound. The fluid tolerance is no, big no. But yes, this patient will be still having fluid responsiveness. So probably I will not be going for more and more fluid. And the recent the waterfall study also says the same thing, that it is only the initial time where your patient needs fluid in acute pancreatitis. The fourth patient is AKI with pulmonary hypertension, presenting with nausea, vomiting with high viscous score. So here definitely this patient, if you are giving more fluid, the risk will be more than the benefit. And the final one, AKI in a septic cardiomyopathy with no congestion but negative passive leg raising. Again, the harm seems to be more, though you can think about giving some fluid with the no congestion and negative the passive leg raising. Now, the last few slides, the facts and the myths. Oliguria doesn't always indicate poor cardiac perfusion, kidney perfusion, because the reduced urine output, as I have told already, it is due to neurohumoral responses due to activated renin, angiotensin, aldosterone system. Increased cardiac output alone is not a goal. You have to try to maintain the tissue or the kidney perfusion. Glomerular capillary pressure can remain low even after resuscitation. Why? In sepsis, this low GFR may persist despite your adequate fluid resuscitation due to afferent arterial vasodilation that is happening in the sepsis patients, vasoplegic state. Norepinephrine effects on the kidney. We all know that it will be constricting the afferent arterioles. So, ideally speaking, physiologically, it is decreasing the glomerular pressure. But overall effect may be to improve the kidney perfusion by raising the MAP. So here MAP comes first, glomerular pressure comes second. So norepinephrine you have to continue if you think that that would be improving your MAP. Over resuscitation is always risky. So always you should not be only depending on fluid responsiveness. Preload sensitivity and fluid responsiveness is okay, but you have to think about that your cardiac output, if it is not improving, you have to stop increasing your preload further or the filling pressure further that I have shown as the mean systemic filling pressure. Electrolyte balance and acid base correction is something which comes second in acute kidney injury. So you have to think about first about the volume status and the kidney perfusion, than the electrolyte balance and acid base correction. Now, some of the specific AKI types at the end in CHF, you have to think about inotropes, vasopressors, diuretics, fluid removal. Don't only go for the fluid therapy. In liver disease, the problem is with splanchnic vasodilation and relative hypovolemia. Maybe you have to think about giving volume expansion and vasoconstrictor by combining vasopressin analog and albumin and terlipressin combination to improve the renal function. In obstructive AKI, the problem is with obstruction. So maybe you have to first treat that, and initially you will get diuresis following the post-obstructive diuresis phase, but that later on may become pathological. So in that situation, buffered crystalloid and electrolyte. Tumor lysis syndrome and AKI treated with RRT. These are other two situations which would be coming to your ICU as AKI. So you have to think about giving crystalloids and also avoid like going for the hyperuricemia, hyperkalemia and hyperphosphatemia. In RRT patients, definitely you have to focus more on the fluid removal part with minimal fluid intake only to prevent hypotension, and you have to also think about adjusting your RRT. Last slide, one slide, because all these slides are mainly focused on the acute kidney injury. But yes, end stage renal disease and CKD, there are certain differences from acute kidney injury. Apple cannot be with equated with orange. Same thing, fluid restriction is the paramount importance in CKD or end stage renal disease. Electrolytes and acid base balance sometimes comes as the first priority. You must have seen in your ICU CKD patient not previously dialyzed, or maybe the patient has missed the previous date of dialysis, coming with the potassium of 7.5. Maybe the patient is right now not in need of fluid resuscitation, rather urgent dialysis for electrolyte correction. Then patient on diuretics and RRT. So you have to think about routine RRT and diuretics for the residual function. And fluid choice in CKD and stage renal disease, always you have to think about low potassium, low chloride. You all know these patients are reserving or preserving the potassium more. But in AKI, maybe balanced crystalloids is the choice. Now, some of the take-home message at the end: critically ill cases, always your focus should be adequate resuscitation without harmful side effects of the fluid overload. Serial assessment with proven hemodynamic indices are the essence for better outcomes. We should always understand and also apply in our clinical practice that fluid overload can directly contribute to the persistence of AKI. Inadvertently, we always think about giving fluid to correct the AKI, but fluid is actually one of the culprit for not the patient improving with all of your maneuvers or interventions. Early targeted resuscitation, in that always think about even fluid balance, even and appropriate rate of fluid removal. Early RRT for fluid balance should be instituted. Use buffered crystalloids over saline to minimize AKI risk, and maybe less is more in the fluid therapy as well. And the time has come where the guidelines have to be taken into, like, always with a pinch of salt, rather than personalized fluid management is the essence. So I know this discussion is never ending, but we need to resuscitate our patients without getting the side effects, and also we should not be drowned with the same amount of fluid that we have given to our patient. Thank you very much for your patient listening.
Yes, thank you, Dr. Sahu, for that very excellent lecture on fluids in AKI. It is very important to understand that less is more is also being emphasized here. And of course, the type of fluids and the dose has to be individualized for a particular patient depending upon the cause of AKI, or if it is a CKD patient, we need to really look into the fact that the patient doesn't go into fluid overload. So we have just one question in the chat box. Should we consider chloride levels while choosing the type of fluids? As hypochloremia is known to have a bad impact on heart failure patients. And do you have any studies on the impact of hypochloremia and other pathophysiology states?
Yeah, Dr. Mohan, this is a very valid question, and we all know that the studies till date that have been conducted, the chloride rich versus chloride like poor fluids. So the inclination is towards, or the forest plot, if you have seen in some of the studies, they have been more towards the chloride poor. But how poor? What should be the content of the chloride in the IV fluid is not very clear, and the literature is not very robust about suggesting that yes, it is always the chloride poor fluids. And now what you have told, that hypochloremia is definitely having a bad impact on the heart failure, but whatever, like, you know, the studies have been conducted, they have thought about that if you are continuing with more and more resuscitation with the chloride rich fluid, so that is causing the intrinsic renal tubular acidosis. The renal acidosis is actually more because the intracellular hypoxia as well as acidosis is more. So where you have to, like, you know, weigh about heart versus kidney. I know you are talking about the impact on the heart, but definitely kidney is not loving the chloride. So you have to now take a like, no, call that how much chloride is actually good for your heart, but that is not causing any impact on your kidney. Dr. Tapesh, anything you can add?
No, I will just like to add that hypochloremia is not really a problem today. I mean, there are no real robust studies. Hyperchloremia is the problem, and hyperchloremia, in a recent meta-analysis published in NEJM, it has been shown now. The debate is kind of over, despite all the basics and the SALT and the SMART studies. There was this meta-analysis published in 2022 in NEJM Evidence, and they looked at 13 RCTs, including basics and the SALT and the SMART studies. And there were 36,000 patients. And it showed clearly that if you used balanced fluids, then the mortality risk was less by 9%. And the risk of mortality was increased by 1%. So that is more or less, evidence in favor of hyperchloremia. And Dr. Mohan, we are not aware really of hypochloremia being studied that well. It's hyperchloremia which is found to be harmful. Hypochloremia work is going on, but at least to my knowledge, there is no robust evidence in favor of either heart failure or your this thing, kidney injury. And in fact, hypochloremia goes hand in hand with hyponatremia, right? Hypochloremia generally goes hand in hand with hyponatremia because salt and chloride absorption is linked in the kidney. So if the chloride level is going to be low, the salt levels are also going to be low, and that is actually going to be beneficial for the heart failure patients generally. That is my understanding. But to the best of my knowledge, hypochloremia is not well studied. That is what I know.
Agreed. Yeah, Dr. Tapesh, completely agree that whatever studies have been conducted, they never have favored that you should be promoting the hyperchloremia. Yeah.
Yeah, thank you very much, Dr. Tapas Sahu and Dr. Tapesh Bansal. Thank you. And one just comment that in patients of AKI or CKD, we can utilize focus, that is renal venous Doppler and ultrasound. to know the renal resistive index or the renal venous flow, and these can really help in identifying patients who can develop AKI at an early stage, and then guide our fluid therapy as per the hemodynamic parameters, which we routinely do in our ICUs. So that was a very excellent lecture. So